Good morning. Welcome to the Florida Health Grand Rounds. We are excited to welcome Dr. Curtis today. Just a few things before we go ahead and get started. All phone lines are muted. Therefore, if you have any questions to ask, we do welcome them. We just simply ask that you type them into the question box, which is located on your panel, your control panel. Today is a little bit different because our presenter is located remotely, so you'll have to bear with us if we have any technical difficulties today. However, we're still offering the continuing education credits like normal, and because today is focused on dental health, we will also be offering continuing credits for dental personnel. If you're interested in those, you can either complete the survey that will automatically pop up at the end of the webinar, or you can follow the link that will be sent to you about an hour after the presentation. And if you don't get either of those links, simply email me at Rodriguez, EDDA@flhealth.gov, and I'll go ahead and send you the link. And today we have Dr. Zabert, the Florida Department of Health Dental Executive Director, here to do the introduction for Dr. Curtis, as well as provide a brief overview of the state of dental health in Florida.
Great, thank you, Anna. Just briefly, in the situation in the state of Florida, things are improving, to summarize it succinctly. It wasn't that long ago, as a matter of fact, it was in year 2011, when Florida was ranked dead last in the nation on all indicators for access to dental health. A lot of changes have happened since then, and it wasn't that long ago in the year of 2017 when Florida actually had moved up to 34th in the nation and access to sealants for children. Another major change that has just occurred less than 2 weeks ago, on February 1st, the quote-unquote carve-out for Medicaid just happened. And that now means that the Medicaid money specifically for dental care is going directly to dental programs and not through a medical managed assistance company. So all of the money earmarked for dental is going to dental. Another major change is that for the first time ever, adults now have full dental coverage, so it covers not only extractions, dentures, but cleanings and fillings. So that's comprehensive dental care. So we're excited to see what the indicators will do in the coming years. So today's presentation is featuring Dr. Curtis from the University of West Florida in the Department of Health. Dr. Curtis is a distinguished figure in the fields of dental and health policy. She serves in diverse roles as the Chief Quality Officer for the Kansas Association for the Medically Underserved, as a UNICEF Ecuador Program Officer, and as an epidemiologist in the Kansas Department of Health and Environment. Welcome, Dr. Curtis.
Thanks for the invitation to share with you the results of the research we conducted in Ecuador a couple of years ago. Okay. This research study was funded through an internal grant from the University of West Florida. We also received toothbrushes and toothpaste from Colgate, which were given to the participants as a token of appreciation. For those of you who do not know where Ecuador is located in the middle of the world. It has three very distinctive regions. The highlands, where Quito, which is the capital, is located, and three of the rural communities where we work with this project were also located in the highlands. This area is surrounded by the Andes. We also have the coastal area and the rainforest, and Ecuador also owns the Galapagos Islands. I'm sorry, but I'm having to pass the, there you go. Dental disease is often overlooked health issue with systemic implications and global distribution. Dental caries is a multifactorial disease, and as with any infectious disease, it adheres to the epidemiological triangle. In fact, we use the epidemiological triangle as the framework for our study. As many of you may know, the epidemiological triad refers to the three criteria needed to determine causality for dental disease. The host is the individual with all their intrinsic characteristics, such as age, gender, race and ethnicity, nutritional status, and socioeconomic status. The agent is a factor that must be present for the disease to appear. Streptococcus mutans has been identified as the most common bacteria related to the pathogenesis of dental caries. Streptococcus mutans adheres to the surface of the teeth and initiate the formation of dental plaque. On the other hand, another bacteria called lactobacilli promote the formation of acid which destroy the tooth enamel. These two bacteria are known for being highly cryogenic and virulent. Vertical transmission from the mother to the child by sharing utensils from mouth to mouth, along with the mother's oral hygiene and periodontal disease, have been well documented as risk factors for dental caries in the child. Horizontal transmission from a sibling or caregiver to the child has also been documented as a risk factor. The frequent ingestion of fermentable carbohydrates is linked to dental caries, as these bacteria colonize the dental surface and cause damage to the hard tooth structure in the presence of fermentable carbohydrates. The environment is composed by all the external or contributing factors that cause or allow the transmission of the disease or prevent it. The environment is also composed by protective factors that prevent the development of the disease. Examples of contributing factors are sugary foods and drink consumption, the mother or caregiver with dental caries, continuous use of bottle or sippy cup, and frequent snacking. Examples of protective factors include optimally fluoridated water, regular oral hygiene, the presence of a dental home, and regular application of fluoride varnish and sealants. Understanding the role of the host, agent, and environment in the development of dental caries is crucial for the identification of primary and secondary prevention strategies. One of these strategies is the use of the caries management by risk assessment tool, also known as CAMBRA. We used the Spanish translation, the Spanish form developed by the American Academy of Pediatric Dentistry, and we made slight modifications to this tool. For example, we deleted any questions about health insurance, such as Medicaid, and we included traditional foods and sweets consumed by these communities. We invited parents and their school-age children, 6 to 12 years, of 3 rural communities to participate in the study. We partnered with the University of San Francisco de Quito because they had been working with these communities for many years. They had built rapport with the community leaders, and they were able to work with the communities and encourage their participation. We work in conjunction with dental providers from 5 dental schools in Ecuador and their students. We trained these dental providers, we calibrated them on how to conduct the visual clinical exam, and we trained the students on how to collect the data about the caries risk indicators and protective factors. I hope you have a chance I hope they provided you with copies of the CAMBRA tool so that you can follow, you can see the data that was collected as part of this study.
Joining remotely, that handout is available on the control panel under handouts. You'll see a copy of both the presentation and the handout Dr. Curtis is referring to.
Okay. For the dental exams, we use mirrors, excavators, and headlamps. The dental exams were conducted in community settings such as schools and churches. We analyzed the data using SPSS version 24, and we received IRB approvals from the University of San Francisco de Quito and from the University of West Florida. So 131 children and their parents participated in the study. The three communities were at high altitude and experienced high levels of poverty. The median age of the children was 8.5 years. There were more females than males, and almost 1/4 of the children had not seen the dentist within the last year. You are going to see the results of this study are not much different that you can find in certain segments of the population in this country. Here we see that 62% of the caregivers reported having a dentist, and 83% reported they had active decay within the last year. A significant proportion of caregivers reported using bottles or sippy cups with juices. They give their babies bottles with Coca-Cola and juices, and providing frequent snacks such as sweets, cookies, and bread to the children. One of the protective factors that we mentioned at the beginning is the presence of a dental home. A dental home needs to provide continuity of care. Two of these communities had a health center within 2 miles. They don't have transportation. They have to walk to the community center, which could be, in this case, considered a protective factor. However, dental care was not always available at these centers, as they are staffed by recently graduated dentists who are doing what is called a year of rural practice, and they have specific hours and days they are required to serve in the community. None of the water systems, which is, this is another protective factor, is water treated with fluoride. None of the water systems had been treated with fluoride. However, one of the community water systems had a very high fluoride level of 4.86, which can be considered a risk factor instead of a protective factor. And 83% of the caregivers reported that children brush their teeth at least twice a day. Here's a picture of a child with fluorosis in this particular community. Through the visual exam, we were able to find 89% of the children had decay, 63% had restorations, 70% had plaque, and 39% had gingivitis. Here's a picture of a child with dental decay. So the primary outcome of this study was to assess the prevalence of caries among school-age children in 3 communities in Ecuador. We found the prevalence of dental caries among this population, among these children, was 89%, which is much higher than the national prevalence of 62%. The secondary outcome of this study was to identify contributing and protective factors for dental disease. We found that the prevalence of caries among the mothers was 82%. As we learned in this presentation, mothers and caregivers are considered to be an important source of transmission of dental caries through their intimate contact with their children during the first and second year of life. Studies have shown that infants acquire Streptococcus mutans from their mothers after the eruption of primary teeth. Our findings also indicate that these were extremely poor communities with very low levels of education. In another study that we conducted in these communities, we found that the average number of years of education was six years, with females having the least number of years of education. We were able to see inadequate hygiene practices and lack of access to oral health services and dental. Yes. Without a dental home, we found poor prevention practices, as dental visits were only in response to pain. The diet, as described to us, seemed to be high in fermentable carbohydrates, mainly potatoes, rice, and bread. As we saw in the results, there was a high prevalence of caries among the parents and caregivers, and we found poor feeding practices to the children. So the strength of this study, as far as we know, this is the first time that the Canberra tool had been used in Ecuador. Using this tool provided us the opportunity to educate the parents as we were interviewing them about the risk factors for dental disease. And we also had the opportunity to train the non-dental providers as to how to use this tool to start a conversation about the relationship between oral health and general health. Limitations of this study, this was a cross-sectional study, and because of this, we cannot show causation. The data was self-reported, so we believe there could have been recalled an information bias. For example, remember that parents said that children brush their teeth at least twice a day. Based upon our visual dental exam and the lack of water, we believe that this could have been a social desirability bias. Another limitation is that we were not able to collect saliva from children and their mothers in order to culture it for the presence of bacteria. We conducted only a visual dental examination of the participants with the use of an explorer, a dental mirror, and headlamp. And if we had had the opportunity to conduct a more thorough exam using a dental office and x-rays, we could have perhaps seen interproximal decay. The sample of this study was one of convenience and was small. Therefore, the results of this study cannot be generalized to the general population. The aim of this study was to understand the risk and protective factors that may have an impact on the oral health of school children in 3 rural communities in Ecuador. I was asked to provide you with a takeaway message from this study. I believe that understanding how dental disease occurs and the role of the host, agent, and environment may allow dental and non-dental providers appreciate the application of Canberra as a prevention and risk management strategy to reduce dental disease. I believe that providers, particularly non-dental providers, miss a lot of opportunities to start a conversation with their patients about how to prevent dental disease. For example, OBGYNs see pregnant mothers at least 3 times during their pregnancy. Pediatricians see children far more frequently than the dentist. During these visits, these providers could use Canberra as a tool to help caregivers understand what the risk factors for oral disease are and how to prevent them. Here is another picture of evidence of fluorosis in Salasaca, in the Salasaca community. Here is a picture of technicians sampling the water system. And if you want to read a little bit more about this study, it was just published this December in the Journal of International Oral Health. Thank you very much, and I'm open for questions.
As previously mentioned, all lines are muted, so please type in any questions you may have to the question box. Our first question wants to know, what was the cause of the increased level of fluoride in just one of in the water system? Was it just one, or what was causing that increase?
These are just natural water systems. We don't know. I brought from as part of our study, I brought the machine to measure because there was an anecdotic report that these communities were having fluorosis in their teeth, and we measured and we found for that high level of fluoride in the water. We just don't know where it comes from. And most of the people in that community had fluorosis, with the exception of a family whose kids were born and raised in the Galapagos Islands, and they came when they were, 6 or 7 years old. So that family didn't have fluorosis.
The next question we have is, when do kids need to go to the dentist to get sealant? Oh, no, sorry. The question is, when the kids do go to the dentist, are they getting sealant, dental sealant?
No, not in these communities. They are not getting any primary prevention. They are not getting fluoride for those communities that don't have fluoride in the water, and they are not getting sealants. Like I said, most of the times when they see the dentist is just for pain management, unfortunately.
The next question we have is, do patients have access to traditional media such as television, radio, and newspaper? Do you think implementing a health education campaign is a possibility?
They don't have electricity. They have radio, mainly with batteries, and of course, not newspapers. So yeah, I think that was part of the follow-up of this study, was to conduct a media education campaign. But I think what we would like, first of all, is to train the non-dental providers that are always in the health center on how to use this tool and start the conversation with the parents. So, Eda, I do have a question for the audience. Have they heard about the Cambra tool, and have they used it?
If anybody would like to answer that question, you can go ahead and submit it through the question box, and I can read out your answer.
I guess my only question would be, how long does it take to do the assessment with Cambra?
That was Dr. Zaber asking Dr. Curtis.
Yes, not too long. I would say for our questionnaires what we had is one student that collected the data from the caregiver, the parent, while one of the dental providers was doing the visual exam. The entire thing would take 5 to 10 minutes at the most. Now, if you want to use the Cambra tool and take advantage to educate the patient, because we didn't have that time, at the end of the day, we sat with all the parents, and we kind of talk about prevention strategies, but when we were collecting the data, we didn't have that time to educate the parents. But if you want to use this tool to educate, then it might take a little bit longer than that, and answer questions. So has anybody used this tool?
We just got a response from a Florida Department of Health dentist working in Polk County, and they said they had not heard of the tool, but they would like to get the link so they can use it. A copy of that handout is available on the control panel. If you go down, you should see a tab labeled handout, and the first one is the presentation, and the second one is the oral health risk assessment tool for anybody who would like to download it or look at it more closely.
And if you go to the American Academy of Pediatric Dentistry, you can find the form in English and Spanish, and the form for children and for adults.
Doesn't look like we have any more questions coming into the chat box. So we'll go ahead and tell you a little bit more about the next presentation. Our next presentation will be March 12th at 10 a.m. and we will be featuring Dr. Alan Becker from Florida A&M. He will be presenting on environmental toxicology training for African American residents and community leaders using participatory-based methods. For those of you located in Tallahassee at the central office, this presentation will be located here and you have the opportunity to join in person. Similarly to this presentation, you can register to the eVite, which will be sent out to everybody in the upcoming weeks. We would like to extend a special thank you to Dr. Curtis and Dr. Zapert for doing the introduction, and Dr. Curtis for giving the wonderful presentation today. Thank you to everybody for joining, and thank you to the Escambia County Department of Health for being the host for today and running the webinar remotely for us. Thank you, everybody, and have a great day.